Welcome to Neuro Connections, a vodcast series developed by the World Stroke Organization and Ipsen. The series aims to shine a light on the experiences of people post-stroke and discuss what's involved in providing consistent, high-quality care to meet their needs. Hi, I'm Dr. Michelle Nelson, and in this three-part series, we'll hear from stroke experts from around the world as we discuss post-stroke care and the rehabilitation landscape. We'll look at solutions to improve patient care, support recovery, and reduce healthcare costs. Stay tuned for some fascinating insights. In the final episode of our series, we're going to be talking about the education and training needs of all of those involved in the care of people post-stroke. We'll be talking about the importance of continuous upskilling for healthcare professionals, as well as the education and training needs of family caregivers and community health workers. In this episode, I am joined by Dr. Jorge Jacinto, a PM and R Senior Consultant and Head of Department of Adult Neuro Rehabilitation at Centro de Medicina de Reabilitação de Alcoitão in Portugal, and Brina Ludwig-Prout, a mentor, citizen researcher, advocate, and caregiver based in Toronto, Canada. Brina, George, it's so wonderful to have this opportunity to speak with you today. It's such a pleasure, and I'm looking forward to hearing your thoughts on workforce considerations, education, and training. So thanks for joining us.
Thank you for having me.
Delighted to be here.
So let's jump into it. I'm wondering, for the purposes of our audiences getting to know you a little, if you wouldn't mind starting with a little bit about who you are and how you come to the conversation about post-stroke workforce or health human resources. Brina, can we start with you?
Hi, Michelle. Hi, George. My name is Brina. I have been a caregiver of a two-time stroke survivor for the last 8 years, full-time caregiver. Although my professional background was in change management and human resources for the last 8 years, I think I've become a professional caregiver, advocating very much for caregivers being solidly included in the care team for stroke patients.
Hello, both. It's a pleasure being here, of course. I am a PM&R physician, so physical medicine and rehabilitation. I have worked in neuro rehabilitation for the last 25 years, and stroke patients are around 70% of my patient population. So I've been dealing with that in the context of a rehabilitation center, so post-acute care. Apart from this, I've been one of the founding members of the National Patient and Carer Stroke Association, and therefore involved a little bit also in patient advocacy in the last maybe 5 years.
Wow, thank you. So I'm wondering if we could start with, in our preparatory conversations, we had lots of conversation about the changing face, the high variability and the changing kind of face of people who are having a stroke. So, George, I'm wondering if you could start from your perspective around what does that mean? What are the implications of that changing patient population for the benefit of our audience?
It's, in fact, something we are feeling more and more, and I would say maybe in the last 2 decades. It's very different nowadays to think about stroke survivors. We used to think of them as older people, senior people that were not anymore in an active, productive period of their lives. But nowadays, it's not like that. We have a significant percentage of survivors that are quite young. So actually, technically, it is considered less than 55 years of age. And therefore, these people are in completely different phases of their lives. And therefore, their expectations, their needs for the remainder of their lives after the stroke are completely different. And we need to cater for that. We need to be ready to actually not only add years to life, but also quality and dignity to those years of life. That's actually, I would say, the situation at the moment we are adapting to.
It's really interesting because, thinking about your point about that over the last 20 years, we're seeing this fairly significant shift in the population. And many of the clinicians who would be working in those spaces would have been trained within the last 20 years or 20 years past. So what do you think, what does that mean for clinicians or healthcare providers trying to provide rehabilitation and adjust to the new kind of patient profile?
Well, actually, for us, it's a sort of no-brainer, let's say. We have no alternative. We are trained more than anything else to try to respond to the needs of our patients. We need to find those responses. What happens is that bit by bit, they have been changing, and we need to find allies that might be other healthcare professionals in a more vast, let's say, array of specialists other than just physicians and nurses and therapists. Maybe we need more the social workers. Maybe we need more the psychologists. Maybe we need more the employment advisors. There are so many other engineers definitely nowadays to help us with technology and adaptation of the work post, of the domotics in houses, of the communication devices, because these people are not geriatric as they used to be. So we need to resort to all these numbers of things. And I would say that because healthcare professionals of all kinds, or even professionals of all kind, are maybe in need, I would think that more and more we need to get the help of the informal helpers, the informal carers, so family members, friends, colleagues at work, voluntaries. These people need to be part of this workforce that you've been talking about.
Thanks, George. Brina, over to you. So thinking about the implications for the workforce and that changing profile, but also that excellent comment about relying on or needing the work of informal caregivers.
Well, it's funny, as George was talking about it, it struck me that when my husband was first in rehab, we were seeing a lot of younger people in rehab, and my husband's over 70s. It was quite shocking to see them. But then the thing that I have been a profound advocate for also in other parts of my life is intergenerational partnerships. We're going to have to look for ways to combine the geriatric and the non-geriatric where possible, because the volumes are just too great. And so it's recognizing the needs of the young people, because it is very different, but at the same time, not writing off the geriatrics who also want to have a full life. And given lifespans, it's longer and longer, so we have more geriatrics living longer, quote, healthier lives as well.
Actually, I could add that, I don't know if you know, but one of the largest studies, prospective studies ever made was in the Nordic countries, in Scandinavia. And they detected that at 15 years post-stroke, 25% of people are still alive. So it's quite a big number that leaves more than 5, more than 10, more than 15 years after the stroke. So their life is not at all near the end when this happens. So it's very important to have that notion that we are not just, okay, let's now just care for him, pamper him, because it's the last years. No, it's not.
And Michelle, if I can just add to that message should be front and center, because it changes the focus of rehab. If you think that people are going to be living for 20 years as opposed to dying in 2, you are going to be doing things very differently. So I think that needs to be talked about in the workforce as well.
Okay, well, let's talk about it. So we talk about the need to think about reimagine the workforce for that extended lifespan. So who have we typically not thought of as stroke support care workforce? Who should we be including or thinking about now?
The thing that strikes me, first of all, is there is a renewed focus on young caregivers. So one of the things that we're seeing is that there are a lot younger caregivers who are either looking after parents or looking after siblings, and we need to make sure that we're finding ways to include them. The other is that community organizations and voluntary organizations that focus on inclusion and helping just people in general to be involved need to have some training and awareness about stroke so that they can adapt programs in small ways. I'm not saying they have to be stroke specialists, but they need to understand what some of those issues may be, because we're going to have to look at more and more that holistic view of young and old coming together and saying, whatever your age is, let's assume you're going to be here for 15, 20 years. And let's assume that you want to be productive. So let's take that focus. It is different than what it used to be.
Yeah, and I think knowing what we know about the likelihood of, 1 in 4 people worldwide will have a stroke in their lifetime. So if you put that and combine it with George's comment about 20 years, living 20 years or more, it does really require us to change our thinking about the workforce. George, I'm wondering if you have anything you want to expand on.
Yeah, just one of the things Brina just said was, I was talking with that one, is you still want to be productive, but productive is more than just working and generating production of a factory or of your office or whatever. It's not just that. It's being happy and feeling dignified as a human being and as a citizen. So you can, sometimes you cannot maybe return to work, but at least you can return to your leisure hobbies, or you can participate in just going to see the hobbies of your grandchildren or of your children or of your wife. So it's more than just going back to work. One of the things I always say is I'm not taking care only of the stroke survivor. I have to take care of their carer, because their carer, if they get injured, if they become depressed, if they get burned out, what happens to that person? And to me, my team gets to lose an element, and my patient will be not so well cared for. So I need to care for all of them. We cannot forget that.
I'm so happy to hear George say that. And the other piece that we need to keep in mind, especially for geriatric stroke survivors, is that often their carers are also getting older and less healthy, and that the things that you may have done physically at an earlier stage of the, quote, recovery period may not be possible anymore. And so often there is not attention paid to sort of the changing health of both the stroke patient and the caregiver.
On the younger segment of this population, the spouse, for instance, is still the resource, the financial resource of the family. So they have to work. They cannot stay home. And their children are still not old enough to help. So this is something we need to really keep in mind. And this
Hugely.
is many times a challenge.
So George and Brina, in episode 2 of the series, we talked a lot about goal-oriented and individualized rehabilitation and care. And, everything that you're saying is evoking that idea that with incredibly variable patient kind of presentations and profiles, that responsibility to try to provide the widest range of rehabilitation activities, offerings, opportunities, that has huge workforce implications. So, George and Brina, you've identified some of the team members that, we would include, but which disciplines or where are kind of partners that we could be thinking about that we have not included yet?
Yeah, employers, definitely. Schools, universities, because people need to go back to their project of life. Maybe with adaptations, but we need that, and we need their collaboration to do that.
There's also one other piece that I just like to add, and it's not necessarily an additional person, but it's a little bit of a change of focus, and that has to do with the assessing that is happening. Because one of the things that can happen, and I'm really pleased to hear about the individualized thing, is you can assess based on standardized results, but in fact, people are not standardized. And often someone may hit the level of the standardized result, but they are so far below their own level of a previous achievement that if you just look at the standard, you are not going to address what their needs are. So something about recognizing that in the training of the assessors, and that may be some of the standard people, speech and language, OT.
Yeah. It's very interesting because there's always the other side. Also, some people may have improvements that are below what we would consider relevant, but actually that little improvement for them can make all the difference. And sometimes this comes about, when do we stop rehabilitation? And sometimes people say, oh, but he's been doing rehabilitation for so long and he hasn't reached this level that we consider to be the minimum functional level for real life, for a person to be able to just help, for instance, just hold himself to a chair or to the bottom of the bed to help change the diaper can make all the difference between staying home and one person being able to care for him or needing to go to a care residence outside of his house because he needs more than one person to take care of him. And we need to keep trying to sensitize people that these minor changes change the quality of life of the person and of the carer. So it's still worth continuing the rehab.
Great segue to one of my questions. So in previous conversations, we've talked about, that recovery isn't static, that recovery can take a long time. Our thinking's expanded beyond the 3 to 6 months post-stroke. We've also talked about how people encounter new challenges or new sort of health issues in that longer recovery time. So, I'm wondering if we can just spend a little bit of time thinking about what are the implications for workforce in that space, whether it be mental health conditions. Jorge, I know you have an expertise in spasticity. So how do we think about that changing face of the health experience and how we equip workforce for it?
Yeah, well, absolutely. And as you talk about that, I mean, there are a couple of things that really come to mind. One is the primary care physician in that situation. So if there is no one else that is following the individual, then that's where it has to come from. Now, an understanding that in the location that I am in, we have 6 million people who do not have primary care physicians. So this issue of coordinated care is a big deal. However, should you be lucky enough to get into some kind of rehab program or constant monitoring, somebody needs to sort of develop the set of questions that go beyond the same question every time. So it's what has changed? What is going on? Do you feel a different need for support? What is your mental state like? What is your, physical state like? Are you less capable than you were before? And that kind of training in terms of the ongoing needs to happen as much as possible. And as well, just to caregivers themselves to be able to say, this, people need new information about this is what you need to look for because you may think your person is the same, but they may not be.
Yeah, definitely. Primary health care is definitely something we need to empower more. We need to educate more these professionals because they are actually the wider tentacles, the longer tentacles of the octopus that we have here. So we hope that they will reach further. They can go to the homes of the patients. They can see locally what are the real resources and what are the real needs and expectations and how they vary along during time. Because patients that had a stroke and survived frequently have other comorbidities like blood pressure, diabetes, and then with age they develop arthrosis, and then they develop glaucoma or short-sightedness, and all this changes the way they function, and therefore we need to always be there to be able to provide solutions for the new problems that come up, and therefore the need of a multimodal, multidisciplinary team to act. We don't have to act, all of us, always. Sometimes we need to direct more to the psychologist, sometimes more to the nurse, sometimes more to the doctor, sometimes more to the family doctor. It depends, but we all need to be there. And the patient is in the center, but he is also a member of the team. And that is another concept that I think we have more and more nowadays. That is empowering patients for self-management. This is super important because it gives people confidence. It gives people self-esteem. And it also allows us to tell them, no, you need to do your part. You're not here to be cared for. You're here for us to help you care for yourself also. This is very important. It changes the perspective of the patient normally.
So, what's interesting in this conversation, as you're talking, George, it strikes me that we talk about workforce for stroke rehab and the extended workforce. And actually, your comments are really, where have we included the person impacted by stroke themselves as part of the rehabilitation team? And in fact, they're the constant through the entire experience. And so that's a very interesting consideration because we are talking about health professionals, caregivers, community health workers, volunteers. But in fact, the constant person workforce is the person. So that's a really interesting insight for me and probably for many of our listeners. So we briefly touched on the topic of spasticity and thinking about some of the ongoing physical functional considerations, new things that may arise. Given what we know about how difficult it can be to either access or re-access rehab, how do we support people living with or experiencing some of those challenges in exercise, physical activity, physical therapy? How do we actually think about that from a workforce perspective?
Yeah, spasticity is a great example because it normally is not present in the acute phase. Spasticity typically appears around 2 to 3 months after the stroke. So when patients are going out of the acute and going into the post-acute chronic phase, and it actually is the number one cause of increasing the disability in patients post-stroke. Nowadays, people like me that have been working in this field for many years are pushing more and more to try and detect that problem as soon as possible and treat it as soon as possible because the results are better. But it is a condition for life. But it actually, once it exists, is not curable. And one of the problems is the access to the first treatment, but on the other hand, also the maintenance of this access, because it's a treatment that has to be done, let's say, three times a year in average. And it's not very easy. Not every center has that capacity. So it is a challenge, but it's something we need to also create the awareness for, because the sooner it is starting to treat, the better the results.
One of the things I just would add is to your point about technology, that there is an opportunity, I think, for coordination of online services, of helping point people to using technology for exercise programs, for, stiffness. I regularly do sort of a survey of the internet on post-stroke care just to see what comes up. And often it's very, very sort of specific, or as something that you read. But as you're speaking, I'm thinking about, videos that show the kind of exercises you need to do after you've had a broken hip, or things that people might be able to get a little bit of support for and then hopefully able to do on their own, which can be very helpful.
This conversation is making me think of, there's a difference between acquiring knowledge, so the independent, self-directed acquisition of knowledge, and where and when and how do we support people in formal education, upskilling, because a lot of what you're talking about is in the absence of formal training or education, people have to figure it out or learn for themselves. So, what are some of the places and spaces that we need to be thinking about, looking to, so to support the workforce, whether it be formal, informal, paid, unpaid, to develop the mindset and the competencies to meet the changing needs?
Yeah, there are two areas, as you were asking the question, that I really thought of. One was just the whole concept of integrated care. So really sort of bringing people together and having them work as a group to figure out what that is and how to deal with that. The other is sort of related, but it's interprofessional education. So if you get to students or even people who are continuing their education early enough, and you plant the seeds of developing changes and developing programming for changing situations, that can really be helpful. And the other is to figure out points of coordination so that people know where to go. So, George, they may know to go to your clinic, but do they have to have a doctor's referral? I don't know. So in different places you have different things, but those two things, the integration and the coordination, I think are really key.
I think the comment about attending to the context is really important too. Knowing that there isn't going to be one size fits all training and education, that it has to be grounded in where people are, where they're working. But I think we know that we want to provide a base level of quality of care for everyone, everywhere. And so it does add sort of a new challenge to the mix. George, I'm going to pass over to you.
Well, of course, we are striving in every, I would say, in every modern society for increase of health literacy. And that is for the whole population. So hopefully that also helps a little bit. But then when situations are concrete, we need to train for the concrete situation. You see, it's not helpful that I am going to teach somebody that has a stroke survivor to care for how to probe a patient for bladder emptying if that person doesn't need it. It's completely not nonsense, but I may need to teach him how to care for toenails because that person has a problem of malpositioning of the toes due to spasticity, and we need to be extra careful in that situation. So this has to be very, very customized. So in Portugal, we're having more and more, for instance, those carers that are professional carers, but lay people. So they're not healthcare professionals. They're professionals that get paid to take care of people, and they are trained for it. In my hospital, for instance, we have voluntaries. But before they start getting in contact with people, we train them. We give them information about the most frequent pathologies and what they can find, what a certain behavior may mean, what a patient which has dysphagia, for instance, they cannot feed him, they cannot give him water, and why, and what are the symbols, what are the codes. This is very important for patient safety, but also for people feeling more confident in what they are doing, more rewarded by their present because they actually feel, oh, I belong to this workforce. I'm not just someone that has nothing to do and comes here 3 hours a day. This is really important. And whenever we're talking of training, we need to talk about repeat. Because we have to repeat. Periodically, we have to go back, refresh the teachings, the whatever we taught.
So we've covered a lot of ground already today. And in each episode of the vodcasts, we've asked participants to identify either a takeaway message or a final thought for the audience. And so thinking about our discussion today around the extended workforce, upskilling, ongoing education and training, what might be one takeaway thought, one brief takeaway that you're walking out of our discussion with? Brina, you have a deep thought, I can tell, percolating. So we'll start with you.
I think that, after hearing this conversation, I would like to investigate getting this message out into the integrated care community and into the interprofessional education community, because I think that if we really sort of synthesize this conversation, there is so much change that can happen by small tweaks that will allow things to move forward. And especially the intergenerational piece, because there is something there we're going to have to figure out to blend young and old where we possibly can. So that I would like to sort of focus strategically on those couple of areas.
Thanks, Brina. Jorge.
Yeah, for me, I think if I wanted to summarize it in short, it would be something like rehab starts the minute the stroke happens, but it has to go on forever during the life of each person. There is no other solution but to make it personalized and patient-focused, or I should say person-centered or survivor-centered. And so the decisions, the needs, the expectations need to come from the patient, and we, the rest of us, the extended professionals, majority of the professionals that are involved, some healthcare professionals, others non-healthcare, we need to come in and out according to the moment, according to the need of that center focal element that is always there. This has to be our way to move forward, because this is just the diversity of patients, the diversity of needs and expectations is not approachable in any other way.
Yeah, thanks for that. I hear you both, and I think I might add my reflection after this conversation is there's a lot of opportunity to rethink who and who the extended workforce is for stroke care and support. That if we think about that individual, there are a lot of partners that we potentially haven't engaged as fully as we can or could. And so driving support and care to meet the needs of people where and when they are, I think is really the takeaway for me. Wow, this conversation has been really eye-opening and has given me a couple of aha moments, as it were. So thank you so much for joining and sharing your insight. It's been such a pleasure, Jorge and Brina, to spend the afternoon with you.
Thank you so much.
Thank you so much.
Thank you, Jorge and Brina, for sharing your insights with us today on the importance of education and training for all of those involved in post-stroke care. This is the final episode of our 3-part series. Over the course of the series, we've covered a lot of topics. We looked at what the state of post-stroke care globally, what good or even great care would look like and how to get there, and then what are the workforce considerations for providing high-quality, equitable care for all. I'd like to take the opportunity to thank all of the participants across the series who joined us to share their expertise, insight, and recommendations. If you want to catch up on previous episodes, search Neuro Connections wherever you find your vodcasts. And thank you to you all for listening. I hope you've enjoyed the series as much as we did.